Oh, looks like we're live. Um, Hello, LinkedIn. Today, this afternoon, I want to take a little bit of time if I catch any of you out. And I wanted to talk about how you can make your treatment plans work outside your walls. And when I mean your walls, is that not only just the physical walls of your spaces that you practice in, but the walls of your practice, where are your opportunities and your advantages are, and then outside of those is where your sphere of influence decreases and you rely on other people to help you. So inside your walls and outside your walls. And I wanted to make that uh you know pretty clear. My idea here is to help strengthen compliance and reduce relapse risk and stabilize outcomes by fixing the family system that surrounds your patient. To me, that is such a big deal. I think it is so overlook the actual support system. I know we have a lot of people to help come in and work with the support system and, give them counseling. But I mean pulling them together as a unit, as a focused group. And there's certain ways I think we have to do that. Um, I'm here representing secondstarts.com. Let's talk about that. I put out a post and got some responses from it, but it was a question. Okay. And the question was, who was helping your client families learn to evaluate, build, and manage their support networks in a way that is guilt and shame free and that prepares them to absorb and benefit from your treatments, your therapy, and your counseling? And that's really what I'm here to talk about. I'm here to talk about ways that we can give you and your subject clients. I want to call them subject clients because I think it's client families and subject clients basically I look at. For most of your time, your people have some type of support group, whether it's effective or non-effective. And I think that sometime uh, we as a community overlook the benefit of human beings. We say we don't, but technically, when you look at what we're doing, we do. And I wanted to try to help put a change to that. Uh, in my opinion, in fact of the matter is, especially in what I would call the young adult to adult demographic, I know that there are a number of complaints about what the system, quote unquote, the system is doing. They complain about it as the system. They talk about the lack of resources. They talk about, you know, the money involved. They talk about big pharma, et cetera, et cetera. But in my opinion, I wanted to make it clear that I do not believe that the system is so much the problem is this lack of using available resources. Um, I think that we're leaving meat on the table, and as second starts, we like to. That's one of the things that we are really invested in is helping you uh, help rebuild the support network structure in order to then again turn around and strengthen your outcomes. And this is a non-clinical approach. I want to make that clear. Uh, I think that's important here to make that clear. Most treatment plans don't fail because of clinical quality. I was just saying they break down in real life. Okay, we we need to proactively address the family and environmental factors that will quietly determine progress. And when I say quietly, I don't necessarily mean quietly. I mean will determine progress. I think that in anything we do, we have to remember this is a people business. When we're dealing with human beings, we're in a people business, and we really can't forget that. As professional as we are in some areas, it's still a people business. Real quick, my name is Rich Jones, RN, and one of the things that I wanted to do shortly post my retirement years is go in and help and do something for everybody that I saw pain through. In my days as a correctional director of nurses, and this is where I kind of absorbed in most of the things that I want to talk about. Uh, Three things were hurting me and giving me frustration to no end, and I saw there was a trio of things that were not quite getting all the power. In other words, to me, those three things coming together, putting their strength together, were only equaling about two and a half, if you can follow me there. And I thought that I could come up with a system that would help everybody involved and give them a little bit more progress. And I thought with a little bit more progress, we inch results up, we help people because every degree of progress we make is a life saved. So Uh, I thought that, excuse me, get a drink. In my mind, we had three things happening at the same time. I had a group of practitioners that I thought were not getting the success they needed or wanted because they felt like their system was letting them down also, and they were being forced to accept what I call limits, the limits of diseases and circumstance. Please forgive me. You go on live and you get nervous. Anyway, three things. I thought that the practitioners that I was working with were excellent. I thought that they really went out to do a good job. They were prepared, but they were facing circumstances that were beyond their control. They were facing an audience that had no reason to listen, at least not past that situation. They had There was leverage against them to listen at the time, but follow through was virtually impossible. And I thought that I saw as certain practitioners would lose their zeal and their zest when normally they were really quite good. And I thought that if we could do something to help them get more in touch with better results, any little bit would help. So I was really worried about the practitioners. And I said I thought they were limited to what I call disease and circumstances, what they were fighting against in the individual, and then the circumstances in which they were treating, and the circumstances in which the person they were trying to help lived in, or their reality. So they were really fighting an uphill battle. Second thing, I thought that parents and support networks were flailing badly, and there were some mechanisms, social worker things to help them, but I didn't think they could help in real time. And I thought that we needed a real time boost in this in order to really pick up the strengths because the third person, the subject, I would call them, um, I saw so many scores of young people in that situation who were, eh, there was this, I put down here, enough potential to sink a battleship is the way I put it. And I thought that there was ways that we could handle that much better, and I wanted to come up with a system that I thought, sort of addressed that. So this is really what I'm here to talk about on this live. So I just told you my story, my three big whys. They meant a lot to me. I felt that this was something that I didn't see a lot of people doing, and I wanted it to be a non-clinical effort. I thought that was extremely important. Even though I've been a registered nurse for years, I wanted to be a non-clinical effort because I didn't want to attempt to step on the toes of any of our other practitioners, physicians, um, mental health people, social work people, the volunteers. We didn't want to step on anybody's foot, but what he wanted to do is I wanted to strengthen them. I wanted to pull their strengths together, and I wanted to the word I like to use to potentiate them. I wanted to make that three equal four or five is really what I want to do. That was my goal. And I really didn't see anybody else doing this. So we came up with a way to come up and help practitioners. We've had some success, no doubt. As a matter of fact, later I'm going to ask you to comment on this. And if you are a any type of practitioner that works in the recovery space and would look to get some help with your client support networks and to make them stronger, please just drop me a line. I'll be happy to respond to you and tell you, what I think that we can do for you and your network and your teams. I think we can be of great help. So what did I think about it? On my mind, I didn't think that I thought that I'd be frustrated because I thought that there wasn't enough urgency in our system. That's what frustrated me about it. Not that the things we were doing, but there's not enough urgency. And I understood exactly why there's not enough urgency. Everybody is going about working as hard as they can, and life is tough for all of us, even the practitioners. So we get on our lane, we learn what we do, we're experts at that. We deliver that product the best we can and hope that everybody else around us carries their ball. You know, uh, I thought that some of this urgency could be to, first of all, we needed to work a little quicker and a little faster, more urgency with cases that where relapse was expected. Where you look at that situation, say, "This is an uphill battle. I know this person, I know the situation, and even though I know I'm giving a good treatment, this is probably not going to work out. But it's my duty to help it out." So those type of things where we know, where we looks at it, it doesn't look like it's good. Uh, Families are unsure how to support without enabling. That's prevalent, obviously. Okay. And you could talk to families about don't enable, but talking and PDFs aren't what really are going to get you over. We need to c- put a system in place that they could use that's intuitive for them. Okay. You see people with a history of stalled progress or repeated setbacks. There's low follow through outside the structured setting that you're providing. Okay. And for any case that really you understand you're fighting against, a lot of real world hazards that will, decrease your chances of success, in helping these people. Okay. Um, Restorative life management, what it does, and this is what we call, this is coined just for second starts, something we can come in and help you with. So please get in touch with us. What restorative life management does is we install a structured, non-clinical system that runs alongside your treatment plan. Okay. And it's a dual track system. And what I mean, but let me explain that. On one track, we build a prompt and response accountability system that trains, uh, follow through, and self-generated drive with the subject. Okay, and this is not teaching that's outside of what you're teaching, outside of what you're treating. It's alongside of it, and is used to strengthen it. Okay, the family support network track is a separate track, and what we do is we teach them how to form, bond, evaluate, and create a different type of support network with a different mindset, and it eliminates the factors of blame, guilt, and shame, which is most important. Um, should you continue to work on those clinically with practitioners working on shame, guilt, those the origins? Yes, but when we're starting a treatment, we cannot wait for those, or you should not wait for those to take full effect before you get your results as far as creating, sobriety and a more healthier life. That should be attacked first, because more than likely the things that are causing the guilt, shame, and the blame are going to take a little while to actually fix. Not just a little while, maybe a lifetime. So what we need to do is find a way to get your treatments settled in, but not really be worried about or having to feel as though those problems had to be fixed first. But what we could do is we could change the focus. We could change the focus of that support group into a different mindset and a different way of, of working out this problem. Okay. I had, and I thought that we could do this. Um, I thought that we could do this in a way that gave me those three missions of intent, and I could work with them, and I could work with them simultaneously. I thought this was very important. It had to be simultaneous. They had to come together as a force. Okay. Three things: therapeutic comprehension, what I call the support network, and the self refueling transformation. First thing, therapeutic comprehension. To me, this is very important. I thought that when we could take a treatment group, client, family, however you want to put it, the subject and the support, okay, and make them evaluate, understand, and assess the assets that they actually have now. That's including your treatments, your counselings, and your therapies, okay, along with volunteer help, okay, along with physical attributes they have, along with situations that they had. And if we could evaluate those things, pull up the strengths, and make those strengths work for them, and put a focus now on the comprehension and the building up of assets, instead of putting all the mindset on just the teaching that you're giving them. And I hope that makes sense. Learning is not necessarily everything that's going to get them out of this and turn them into a force of production. And that's, to me, that's what I was looking to do, help turn them into a force of production. Because in my mind, regardless of how much treatment or therapy or anything you take a person through, if they don't have a drive to move in a certain direction themselves and create, it's never going to work. That's the only way you can really be free from relapse, a drive in a separate direction. Because as you well know, all the hits that you take from trauma and all those things are very pervasive and difficult to deal with. But the one thing that can overcome any of it is a force of drive in another direction. So we take all that stuff, therapeutics, and we patch that together with an ability to recognize, isolate, and eliminate the distractions that strengthen everything that would hurt that drive or that comprehension. So we take those two things, we isolate, we identify, we isolate, and we eliminate distractions, and we increase the therapeutic comprehension of all the assets and abilities and tools that are available. So first of all, we want to strengthen that. That's at the same time, simultaneously, we are changing the nature of the support network. That's very important. We're changing how the support network operates, what its mission is, okay, how it deals with each other, okay. We take away the guilt, shame, and blame because it's very difficult to work in the guilt, shame, and blame. And we have a lot of excellent, hopefully, some of you are listening now, some of you excellent people that work with people with guilt, shame, and blame. That needs to be a continued work, and that needs to be focused work. So, what we try to do with Second Starts is create a network that is focused on a way that can strengthen those things instead of trying to replace them. Families, a lot of times, the support networks attempt to do things that they're not capable of doing. They're great at offering support, but helping heal, sometimes that family dynamic is not prepared for that. And by the time it is, a lot of damage can be done. So in order to get the recovery off to a strong start, you need to find a way to move around that and give that support network a different focus and a different way to look. And that is a system that can be installed easily and work with. And we at Second Starts, one of our main goals. We take that support system and rebuild it and strengthen it and give them a new focus, which is extremely important. Okay, and the last one's the self-refueling transformation. And what we mean by that is this. The transformation in the person or the individual or the subject client, okay, even though it can be aided by all the teachings we can give, it has to be something that is innate, intuitive, okay, and it has to be delivered systematically, okay, and it has to be delivered in a way that can be refueled by their own resources, okay. And when I say their own resources, I mean taking from what we use in therapeutic comprehension, coupling that together with the other resources that are taught in order to help them use and be a thriving and forward moving unit, if that makes any sense. So that was the whole thing. To take those three things, those three forms of those three missions of intent and put them together in one physical, easy to use, easy to install, intuitive, okay, customized plan that was built solely to increase the efforts and the outcomes of what I call frontline practitioners, the physicians, the psychiatrists, counselors, and even some of our volunteer situations, whether it be a 12-step program or anything. I think that we like to think that a restorative life management program will aid in all of those and give all of those extra strength. If I don't get anything across, that's what I want to get across, that a restorative life management program will multiply the efforts of whatever you're actually doing now. And that's, to me, that's most important, extremely important. Um, Boundaries. And when we talk about boundaries, because as a non-clinical entity, we knew we needed and wanted to have boundaries. The only way we could bring everybody together is definitely not try or attempt to compete with what's already going on. Our mission was to make everything stronger. So we certainly didn't want to cross any lines. We wanted to bring more service and value to the table. So again, a non-clinical modality that is installed. Okay. So it's not a therapy, it's not a medical service. Okay. And it does not interfere with any of your treatment plans and does not replace any level of care. It is there to strengthen all levels of cares. Okay. Um, there are situations in the program which clinical direction can be installed, but that would be a situation where the client, subject client, the client support network, and the practitioners involved, referring practitioners would be involved in that. And it's something we can work out, but it's not primary to the program. Our program could work separately in order to help, make your outcomes better. No doubt about it. Uh, why does it work? Well, first of all, it closes that big gap between your treatments, your services, and real life. Okay. What it does is it takes real life and brings it into a mold that can be used. Okay. It reduces what we call family driven setbacks and friction. Okay. And it creates a sustainable compliance, not a temporary motivation. It's most important. This is a sustainable modality that is delivered in a set period of time. It's not ongoing dependence. Okay. We want to build what we call long term independence and external structure. And first of all, and last of all, rather, I wanted it to be a situation that was financially fair. And this is not to scoff at anything that you're doing with, insurance works, but we wanted to do something to where if the client, subject client, and the network did not feel as though this system was working for them and working in their best interest and giving them extreme value, then they didn't have to offer compensation. So this is a work for you uh, custom installation and program. Work for you, and that's it. If it doesn't work for you, it's not anything you have to pay for. One of the things statement I can't stand, and I've written it a couple of times, and got some flack for it. When we say, well, they weren't ready. I believe pretty much everybody's ready. They may not be ready to do what you want them to do, and they may not be ready to do enough to help themselves. But one thing we know is they're ready. They're sick and tired, but do they understand and do they trust the direction, or do they have enough courage to take the direction shown to them? But they're ready. But the question is, do they have enough? So what we hear a lot of times, well, they just weren't ready. So we had to leave them behind. They insurance paid the $30,000, but they weren't ready. So they'll relapse and do it again. And we're fine with that. No, we're not fine with that at Second Stars. Okay. We need to take your people and give them a level of drive, direction that helps them to overcome these setbacks. So that's important. So again, that's Second Stars, the number 2, NDSTARTS.com. Please, if you look in comments, you'll be able to see that this is something that we do and we're proud of, to help clinicians. I start from the beginning and I want to read it again because I think it's very important. Okay. It's very important. And it's the essence of really what we do. The question remains, who is helping your client families learn to evaluate, build, and manage their support networks in a way that is free from guilt and shame? And it prepares them, listen to this closely, it prepares them to absorb and benefit from your treatments and therapies and counseling. That's the most important part. I don't think that it's necessarily logical or necessary for the frontline practitioners to change what they do. I just think we are missing a gap in bringing the two together and making situations work. And if I don't express anything else in this live, I want to express that I think that there's a better way. And I'm going to be on here pretty much talking about this every day because I'm passionate about it. I think that we can get better results. I think that we can leave the they're not ready for it model alone and only accepting that 24% success rate and forcing the school of hard knocks and pain to be the judge on when somebody's ready. Let's try to give them a better opportunity to be ready by giving them a couple extra tools in the tool bag in order to take advantage. I think I want to make that clear. Take advantage of everything that you're doing. So hit me up or a comment under this if you see the replay. And please, I'd be happy to get in touch with you, talk about the system. I have a white sheet that I can send you right away. I have a small video that I can send you right away to get you more acclimated to what we're talking about and how we can bring you value. Because the only thing we want to do is increase the results that you're getting and increase the compliance that you're getting and really bring up by a number of percentage points our success rate in applications by strengthening what you do and strengthening the family units and giving a long-term independence to your clients and their families. Thank you.